Hey, this is Dr. C again. Hope you're having a good day today. I just got my shots, so I'm having a so-so day today, but I'll be fine tomorrow. That's okay. Make sure you get your COVID shot and your flu shot now. Okay. We're going to talk about veins today. Veins. Now, once, I think about 2 years ago, we had a program on veins and followed up with a program on arteries as well. So, but I wanted to emphasize different things this time about veins. We're going to talk about the real tiny things too, the ones that occur in your capillaries. They're called spider veins. We're going to talk about those as well. Now, you remember veins, because back in the old biology class that you took, arteries bring the blood down from the left side of the heart and then goes into the veins, bring it back to the heart. Well, yeah, that's a simple thing. They're transit vessels, transit. They bring it down, bring it back. But that's not the only thing that veins do. Veins are very thin-walled. They don't have much muscle in them. They can expand quite a bit. In other words, they're also capacitance vessels. They can take a lot more volume of blood than the arteries can. And so that the body has to adjust to all the time because they've got these capacitance vessels, the veins, in their system. And so, how much capacitance do veins have? Like, for example, if I simply stood up, lay down, stand up, there's over 500 ml, about a half a liter of blood that will then accumulate a little in the lower part of the body. A half a liter. Now, if I lie down and raise my legs up, that half liter then goes into the main system of the blood vessels. So it's like getting a transfusion, simply raising the legs up like that. Amazing the capacitance that these vessels have. So let's talk a little bit about some of the things that can happen to blood vessels. Now, remember, arteries go into smaller blood vessels, arterioles. They go into the little capillaries. The little capillaries then feed all the tissues in the body, bring oxygen and nutrition to all the cells in the body. That occurs all over. Now it has to get out of there. So it goes into the little tiny venules and then into the veins and back up to the heart. And then that whole thing happens again going into the lungs and back from the lungs as well. So you get these two circulations going on. So what about, we'll start with the smallest of all of these blood vessels, and that is the capillaries. Capillaries are not necessarily arteries. They're not necessarily veins. They're kind of a circulation in itself. Some of the capillaries that before it goes into all the tissues and all have a little thing in them, a little piece of muscle around that clamps down. So they can cause resistance to blood flow. And that's very sensitive to some of the hormones in the body as well. So that's another function of blood vessels as well. So let's talk then about those smaller, the real small capillaries. A damaged vein, like a little damaged capillary, for example, that can happen for a number of reasons. Say a punch, a ball hits you, it damages the little tiny blood vessels in that area. May show up as a bruise at first, and then you forget about it. And then later in life, you begin to see these little, what they call spider vessels coming in. Little spiders. Now, how does that happen? Because the little venules or the little capillaries in that area were damaged. Now, the veins themselves have what they call valves in them. And that's why when you suddenly will stand up, your blood pressure doesn't suddenly go down and you get dizzy. You may if you're on some medications and all, but those valves will prevent the sudden drop of the fluid into those veins. So that minimizes the drop in the pressure inside those veins, the valves. So if you damage those valves, that purpose then is gone. The valve doesn't prevent backflow. There is backflow then. And that's what causes increased pressure in the little vein or capillary. And it shows up eventually as a spider vein. Now, spider veins can be any color. They can be red, they can be blue, they can be purple, whatever. Depends on how much oxygen is in the blood. So they don't usually cause any symptoms. Usually not. But a lot of people don't like them. They don't like them at all. And so they try to get rid of them. How do you get rid of spider veins? Well, before we talk about how do you get rid of them, what would put you at risk to get those spider veins? Usually the spider veins occur in the legs or maybe even on the face. They can occur anywhere where there's trauma to the surface of the body too. But mostly it's on the legs and on the face that people worry about it and want to get treated. So what puts you at risk to get spider veins? Well, overweight. If your BMI is over 30, in other words, you're very obviously overweight, that's not a good thing as far as the spider veins go. The most common form of the spider veins are genetic. In fact, over 80% of all of the spider veins that are in the legs are genetic spider veins. Your mother had it, you're going to get it. That's the way it works. I've taken care of many, many people, mother, daughter, down several generations actually, where they come into the office with spider veins. So it does happen, and genetics is a very important component. Now, why does it happen more in women than in men? Well, because estrogen is involved. That's the female hormone, estrogen. So if you're taking additional estrogen, like say a birth control pill, for example, during pregnancy, for example, you are more prone to get spider veins. Pregnancy is a risk factor, no question. There are some, and trauma, of course, the trauma. Now, for the facial ones, the trauma may be just excessive sunlight. That can begin to break down a little and injure these little capillaries in the face as well. I saw a number of women in my office who roll up their stockings. I should say roll down the stockings so that they're tight. They're tight. And so from that point down, there was swelling of the tissue and the beginning of spider veins. So simple. Roll the damn things back up or don't wear them, one or the other. For God's sakes. Don't hurt yourself. Don't cause them. But that is one of the things. There are people with connective tissue disorders too, but those are in the minority of numbers. So those are the causes, and those are the risks. If you're a smoker, you have a greater risk of having spider veins as well. Over age 60, you are more prone to get spider veins as well, for a number of reasons. Number one, you don't have those nice connective tissue under the skin. Skin gets thinner. You don't have the muscle strength to help to squeeze that blood out. So that's why the elderly get more of the spider veins. So how do we treat the spider veins? What do we do for treatment? Well, of course, And we're talking mostly in the legs, but we'll add in treatment for the facial stuff as well. For the veins in the legs, people will use maybe some elastic compression. You don't need a lot of elastic compression, but certainly a little bit of elastic compression. You don't need to get prescription elastic compression stockings. You only need to get the graduated compression stockings that are on the market. Now, since a lot of the spider veins occur in the thighs, the usual ones below the knees aren't going to do squat. So you'll need compression all the way up, like pantyhose type. And so the pantyhose type are stronger compression at the ankles and a little less as it comes up over the pants. Okay, so elastic compression. You wear it during the day, you don't need them at night. What else? Well, there's a variety of creams that are on the market. And there are some of the companies, they think that horse chestnut seems to make a difference in the degree of veins. Well, what the heck does horse chestnut do? Well, horse chestnut basically will just constrict the veins a little. Just constrict them a little bit. So, yeah, it is a little effective, but it's not a permanent treatment, that's for sure. It doesn't eliminate them. It only makes it look better temporarily. So, if you want to get the creams won't hurt, but creams may only help a little, and that's temporary. Okay, what else? Well, people will use things like witch hazel, for example. That's an astringent, witch hazel. Probably, again, very temporary, very temporary. I wouldn't even advise people to use it. But there's roughly 12 plus different ingredients in different creams that are put in to constrict the vessels a little and make them look better. Again, all temporary, not worth your money, most of them. What else? You can use a laser. Now, when I was treating venous disease in the office and all, I was offered a YAG laser, which is what they use now. The YAG will pick out a particular color, for example, like if you're aiming for some little blue streaks and all, it would concentrate that laser onto the blue streak. And what it does, just get the laser to work, and it will dehydrate that little venule or capillary, whatever happens to be the cause of the spider. So, but that takes time. There are some people come in with hundreds of them. So it may be a number of different visits before you really see a very good effect. I also did a lot of injections, sclerotherapy it's called. And there's a number of sclerosants that are on the market. I happen to like, when I did the ones, I happen to like the high concentration salt solution. It's called hypertonic saline. Now, the ones that are on the market are up to maybe 7 or 8%, which is a heck of a lot. Remember, ocean is only 0.3%, so 7 to 8% salt solution. I was using a 23% salt solution. That was prescription only, 23%, hypertonic saline. And so I used a very tiny needle, an 80 gauge needle, very, very tiny, and you get very good at it after a while. I could get that needle into one of the little spiders and then slowly inject and then pull it out, put your hand on it, compress it, allow that saline to sit for a few seconds into that little channels and all, and hopefully it would cause that little, what they call telangiectasia, that little abnormal vein or whatever, that little abnormal vein to shrink down and stick together. Clotted completely. Okay. So that's how the stuff works. And then I usually just wrapped them with an ACE wrap, and out you go. Tell them don't run around for that rest of the day. Tomorrow, go ahead, exercise, fine. Not that day, not that day. Now there's other things that were injected. You could inject what was called sodium moroate. Sodium moroate. And what you can do with that too is the moroate solution, if you squish it through 3-4 times in that syringe, you can make a foam. And so you can actually inject the foam into that little channel that goes to all these little venules or whatever you want to call them, these telangiectasia, and that foam then will sit in there and cause inflammation, collapse the vein. So sodium moroate in the form of either liquid or a foam. Now also today they're injecting things that will cause the vein directly to stick, the walls of the little venule to stick together. So you inject in a little stuff that will immediately cause inflammation and stick together. So it's like a glue. Not a glue, but it's like a glue. Okay. So that's another thing that's out on the market today. So we talked about creams, we talked about sclerosants, we talked about laser, and we talked about the support on the veins themselves. Okay, what else? What else? Well, obviously there's larger veins. There's a superficial vein system, the ones that you can see. You know, you can see these superficial veins. You can't see the deep veins because they're inside, in between the muscles and all. That's where the deeper veins are. What can happen to those superficial veins? Well, you can get a phlebitis, a blood clot in that vein. One of the more common causes of a blood clot is having an intravenous line sitting in there and then putting a certain solution in there, not just the solutions that you get. If you're going to have surgery or something, they'll give you some. But that stuff isn't going to clot a vein. What clots the vein is that catheter that they put into the vein and some of the solutions that they give. Like, for example, if you're getting chemotherapy, that's very, very toxic to the wall of the vein. And also, the stuff they inject when they want to take an x-ray. That stuff also is quite toxic to the vein. That frequently will cause a superficial phlebitis. Now, another cause of superficial phlebitis is cancer. There are certain cancers that will excrete into the bloodstream a substance that will promote clotting. Typical ones are cancer of the stomach, cancer of the kidney, cancer of the pancreas, cancer of the ovary, cancer of the prostate. All those are particular cancers that can cause clotting in the superficial vein. Okay, so those are the main causes. How do you treat it? Because when you look at it, there's a lot of inflammation because it's right under the skin. And so a naive doctor who made all of his learning online, never saw an actual case, when they see that redness and all from the inflammation, oh, you got cellulitis, an infection. They have no idea. But you get a lot of redness. It looks like, to the untrained eye, it looks like a cellulitis, but it isn't. And so we treat it locally by just putting in a moist, warm wrap and rest. That's the treatment. And we change that maybe 3-4 times a day. So external heat, moist heat, and rest. That's the treatment. Now, occasionally you may get a superficial phlebitis in the main vein, that saphenous vein coming up the leg. Now, if I see that, I'll feel, you can feel that clot. I'll feel it, and then put a little line at the end of the phlebitis. Why? Because the next day, when I see that leg, if that line now is no longer at the end of the clot, but the clot now extends up further, now I get a little concerned that the clot may even extend into the deeper system of veins. Now remember, there's a lot of connecting veins between the superficial veins under the skin and the deep veins in the leg. So we don't want that to happen. Occasionally, then, we may recommend that we just tie off the top part of that saphenous vein or put them on an anticoagulant. Much safer under local anesthesia to just put a tie on the damn vein. But there's some people so scared of any kind of surgical procedure, they'll take the risk of going on to a blood clotting, a preventing substance like heparin. Ridiculous, but that's the way they think. So now, the main one is deep venous thrombosis, the ones that are in the bigger veins in the body. Now, you can get 3 different kinds of deep vein clotting. You can get the ones in the calf of the leg, in isolated vessels in the calf of the leg. You can get them all the way up to the groin. They call it the femoral vein thrombosis. And then you can get iliothrombosis, the big vein coming up inside, connecting to the inferior vena cava. Okay, 3 different presentations depending on how far up the clot has gone. They're all treated, however, with a blood thinner. We start out with heparin, which is an intravenous treatment or injection, one or the other. You start out with heparin, and then you convert them over to an oral form. Usually we use Coumadin. Nowadays they may use one of the newer forms. They're tending to get away from Coumadin a lot now. But that usually is a 3-month to 6-month treatment plan, depending on how high up the clot has gone. The only danger to a clot, well, there are 2 dangers. Number 1, a piece can break off and go to the lung, called a pulmonary embolism. That's the biggest risk. Because if you get a big iliofemoral thrombus up in here, then if that big piece breaks off, it can plug off an entire pulmonary artery. It's a big, big sucker, big sucker. So that, and that can kill you. That can kill you. So, but that's the worst of all of them. The worst area to have a pulmonary embolus is clot that's in the vein, that's the big vein that's in back of the knee, called the popliteal vein. Why? Because that joint is working on that clot all the time, and it can knock it off. That's the reason why, because of the motion that occurs at that joint. So, okay. So let's go on from there. I mentioned there were 3 types of veins, 3 types of venous thrombosis or clots. Let's deal with the calf first. People are at risk with trauma usually, or inactivity, sitting for too long, for example, a long plane flight, cramped seat, not moving your legs around. So sitting a long period of time, like on a flight, that's the worst. That's the worst. So that is usually a cause of calf clots. When it goes up into the popliteal and into the femoral, there are different etiologies, different causes. Trauma is a cause. Trauma is a cause. Let's say you fractured the leg. That leg is immobilized. If it's not elevated and immobilized, you back up the blood stasis in that bloodstream, and clot can occur in that popliteal and femoral area. Now, the iliofemoral is a very specific one. And the treatment of that, as I mentioned, is the blood thinner. That's always the number one treatment. But occasionally we have to do surgery, remove the clot. Now, if you get that at an early stage, you can actually make a little incision in that bigger vein, pull out the clot, stitch up that vein, and then pray that that stitch line doesn't promote more clot in that vein. That is called a thrombectomy, removal of a blood clot. And occasionally, I got called on to do a thrombectomy. I've done it on upper extremities more than lower, but also occasionally we had to do some in the lower extremity as well. Now, occasionally too, we have to do something to try to prevent pulmonary embolism, that clot from breaking off. And so what we did is we would put a little clip on the inferior vena cava. We slide it under and over and clip. And what the clip looks like inside, there's two ends to it, and there's little partitioning on the inside. So when you clip it down, you can still get blood through, but a very small hole so that it prevents a big clot from getting through and causing a major pulmonary embolism. So that is an IVC, or inferior vena cava clip. Oh, I think I've talked enough about veins. We didn't deal with some of the sequelae, which we did last time. We talked about chronic venous stasis disease, but that's not my purpose today. Today I wanted to talk about some of the smaller veins, which we did, and not to worry that much. Who gives a crap, really, about having a few spider veins? This is Dr. C. Have a nice day. Get your immunizations now. Bye-bye.